Good evening. Thank you for joining us for our back pain webinar at the Adena Orthopedic and Spine Institute. Today we're going to focus on some back problems, causes of back pain, treatment options including non-operative treatment options and surgical treatment options, and various treatments that may be right for you. We encourage you to send in some questions. We'll answer those questions live when they're submitted. And my name is Dr. James Fleming. I am an orthopedic and spine surgeon at Adena. I've been here 17 years. And today I have two esteemed colleagues of mine in the Spine Center, Dr. Lulu John and Dr. Blake Walker. I won't steal their thunder. Dr. John, we'll start with you. He's our interventional pain physician, or one of many. Tell us a little about yourself, your training, where you're from,
Yes.
why Adena, whatever you want to tell the audience.
Yeah. Well, my name's Liju John. I'm an interventional pain management physician here at Adena. I did majority of my training in Syracuse, New York, at SUNY Upstate, physical medicine and rehabilitation background with a year of interventional pain management fellowship. I eventually started here at Adena a little bit over 3 years ago, and it's been a great ride just being exposed to this population and dealing with chronic pain. And you know, what's great is now we have my good friend Blake Walker here, who's a neurosurgeon and highly well trained, and so it's nice to have him here along with Jim Fleming.
Yeah, I'm an old curmudgeon. It's like, you see, we selected the young, handsome guys for this webinar. So I'm glad to move it on to the younger set. Dr. Walker, tell them, you're like my right-hand guy in spine surgery. Tell them a little about yourself.
My name is Dr. Blake Walker. I'm a neurosurgeon specializing in complex and minimally invasive spine surgery. I trained in Detroit, Michigan, as well as Roanoke at Virginia Tech. Came to Adena in August of this year. I've been thoroughly enjoying my time working with a bunch of excellent colleagues who care about their patients greatly, so it's very nice to be in a community that cares.
Thank you. Anything else? You don't want to tell them you're from Michigan, though, do you?
I don't want to mention that.
Not after the game a week or so ago. Mm-hmm. Understood. Okay, we'll start with the back basics. So Dr. John's going to lead us in a discussion on some of the common causes and non-operative treatments for back pain. I'll let you take the floor.
You got it. You can go to the first slide.
Next slide.
Yeah, thank you. All right, so what exactly is back pain? Obviously you have your spine. You can break it down into three sections: your neck, your low back, and you know, obviously the mid back right in the middle. Obviously the low back is one of the most common chronic pain that we treat, and we'll get into whether it's joint related, neuropathic, nerve related, disc related, or whatnot. But you know, obviously chronic pain, especially when it's in the low back, can be severely debilitating, even if you're trying to do something simple as stand or walk for long periods, or if your job sort of requires that. And so that's kind of where we start. Yeah. Do next slide. So I would say this is one of the most important slides I'll probably talk about, and it's really prevention. And you know, it seems so simple, but very difficult at the same time. I feel like as we stray away from this, as we get older, the more medical problems we have, and our goal is to get back to this. And so, you know, daily exercise, what is exercise? If you're able to walk at least, you know, 20, 30 minutes a day, 3 times a week, maintain a healthy weight, balanced diet, you know, not eating a lot of processed foods or foods that can cause a lot of inflammation and kind of counterproductive in terms of wound healing. Obviously smoking decreases our ability to heal. And you know, properly designed furniture, I think that's more specific for your work station. A lot of times we've tried to transition to working from home. So a lot of times you want to have a ergonomically stable setup, and obviously proper lifting techniques. If your job requires you to lift heavy objects, you know, you don't want to bend at the back. You kind of want to use your legs as much as you can. So obviously our goal here is to identify the source. So, you know, until we really identify, we can't really come up with a great plan. You know, when you say you have back pain, I know it's tough, but there's several structures there, right? There's multiple joints, multiple ligaments, multiple muscles, disc, and we'll kind of get into the most common structures that we treat. So obviously some causes of low back pain: poor posture over time, obesity, just overweight, a lot of stress on the low back. Smoking obviously decreases the ability to heal. Trauma, if you're unfortunate in a motor vehicle accident or just in a traumatic event. Obviously osteoporosis as we get older. Our bones become more brittle, and disc problems, which Dr. Walker will touch on here in a second, and as well as arthritis.
What are some of the somatic causes of low back pain?
So a lot of the somatic causes is joint related in nature, and this is a good slide. One of the most common joints that we treat, whether in the neck or the back, is the facet joint. And it's a joint, so it's very similar to your hip, knee, or shoulder. It's a joint, just much smaller, so it's a little bit harder to appreciate it. But this is the pain that when you stand up erect, it kind of rubs, bone-on-bone contact, and that kind of pain kind of radiates across your back. I'll give it, if it gets severe, it can kind of radiate to your buttocks, but this pain, this back pain, is not radiating all the way down your leg to your distal foot. Joint pain won't cross another joint, like it's not going to cross your knee or whatnot. So this is very common. And obviously this type of pain is worse with extension when you're sitting upright or standing upright, leaning over a sink, doing dishes, using the sweeper. It's very common as we get older as well. So this is, and we'll get into the treatment here in a second, but. So, if you remember the first slide, the facet joint, so you can see how the two vertebral bodies make up one joint. And if you see that nerve in the red, it's kind of showing impingement. So what that white probe is, it's called a radio frequency probe, where literally the tip of my needle will heat up using radio frequency waves. And so we actually destroy this nerve. And it's not a nerve that goes down your leg and gives you function. They're pain nerves that supply the joint. And so we actually do two diagnostic blocks, two test blocks, to see if that's where your pain's coming from. And if it is, we can do something about it and destroy that nerve.
So just for the audience, the facet joint is out here, the nerves run here, but these are some sensory nerves that you cauterize to get rid of some of the pain that they have in the facets. Is that correct?
Absolutely, absolutely. So we do two diagnostic blocks. So what's a diagnostic block? It's just where we're putting numbing medication over those specific nerves. A positive block, our office will call you the next day. A positive block is 80% relief before the medication wears off, even if it's for a few minutes. And then we'll take you to the second diagnostic block per insurance guidelines, just to also confirm as well before we go ahead and destroy that nerve.
So a pearl for the audience is if you're extending or leaning backward and you get back pain with that, that could be facet-mediated pain.
Absolutely.
Okay, next. Other causes.
Yeah. So this is another somatic cause. This is another joint. You can see how close it is to the facet joints. This is the SI joint. It's where the sacrum meets the ilium, as you can see right there. Another very common cause of back pain. Usually this pain is localized to the back. You can actually press on the SI joint. We have some maneuvers to kind of let us know if your pain's actually SI joint mediated. So this pain usually hurts when you're sitting for a long time and getting up from a seated position. Very simple. It's another joint like your hip or your knee or your shoulder. So we can easily do a steroid injection into that joint to see if that helps alleviate, not only treat, but diagnose that pain as well.
Yeah, so with this pain, you can often press on the exact spot where the SI joint is posteriorly in the back and get an index of suspicion that might be caused. So that's two good ones. Next slide.
Yes. So another somatic cause, this is a picture of the disc. Obviously we have disc in between each vertebral body, kind of like a shock absorber. So obviously, the incidence of a degenerative disc or disc issues is high. It's 40%. So, when you say someone has back pain, is it joint related, and which joint is it? And then obviously second, is it disc related? Because we're talking about different treatments here. So obviously, the disc itself will cause you back pain because the disc is located in the back, but at times that disc bulge, and Dr. Walker will get into this as well, when it presses on the nerve root, it can kind of send a signal down the distribution of that nerve. So what does nerve pain feel like? Some of you out there if you're common with the sciatic nerve, if you sat on a toilet seat for too long, that's nerve compression. You'll get numb and tingling along the distribution of that sciatic nerve. And what happens if you don't get up and relieve that compression? Numbness and tingling turns into weakness. So this is a picture of a disc herniation causing nerve compression. So you can see above and below that yellow arrow, the spinal cord has plenty of room. At that level, you can actually see that the vertebral body has slightly translated forward, causing even more significant impingement. So obviously you can, there's a reason for back pain there, and you can't see it, but as the nerves course out, now you've taken up space where the nerves lie, and nerves don't like to be touched. It's very simple. So, you know, when they get compressed, you feel symptoms along the course of that nerve. And so just to break it down, you know, somatic causes. Most of the time we're dealing with joint pain. What can we do? We talked about the facet joint. We can do a diagnostic blocks, and if that helps, hey, we can burn those nerves, or otherwise called radiofrequency ablation. The SI joint, we usually start with diagnostic blocks with the steroid injection into the joint. We could take it one step further if the steroid injection isn't really lasting that long. Very similar to the facets, we could block the nerve supply to the joint and radiofrequency ablate those nerves. And Dr. Walker, as well as Dr. Fleming, they also do fusion of the SI joint, which they'll get into later. And what we talked about, radicular or neuropathic pain, I mean, obviously, if a patient's coming to me, something I do very commonly is epidural steroid injections, kind of put steroid at the focal problem in hopes that we can prevent surgery down the road with physical therapy. So obviously somatic or referred pain, it's usually worse with extension. Like we talked about the facet joint. As you stand upright, the joints are kind of hitting, and as you bend and twist as well. It's a focalized pain, right? So it's in your back. You're not going to feel it shoot down your leg. It can cover a wide area across your back. Obviously the back pain is worse than the leg, and it's not really correlated with numbness or tingling. You know, I'll give you a burning sensation in your back, but definitely not below the knee or in your foot. So neuropathic pain, nerve-related. Nerves, you know, think electric, shock-like. It can cause a nerve-type sensation, as well as paresthesia. And usually, you know, it's when a nerve gets compressed, you feel symptoms along the course of that nerve root.
Can you get into, you've given us a good background of somatic and neuropathic pain, different things that cause back pain, and there's a lot in the audience going to want to know how to treat this. Can you get into some of the non-surgical treatment options so people don't think you need to have surgery for this all the time?
Yeah, obviously, you know, whether you come to our pain management clinic or not, we always want to start with conservative measures. What are conservative measures? Obviously, gentle stretching, physical therapy regimen, heat or ice really helps keep down inflammation. You know, obviously, if it's acute pain, you want to use ice, but to help reduce inflammation. But chronic pain responds well to both heat and ice. Very simple, 15 minutes on, 15 minutes off, and you can repeat as much as you like. Gentle stretching, I mean, I think we take this for granted just to keep the joints mobile and less restrictive. NSAIDs, Tylenol, ibuprofen, meloxicam, we use this to kind of help decrease inflammation as well from a medication standpoint. And as well as topical pain reliefs. You know, many of you have probably heard something like Voltaren gel or lidocaine ointment or whatnot. But obviously we just want you to return, you know, our goal is to return everyone back to their prior level of functioning, whether that be with physical therapy, medications, or even surgery. Like that's our number one goal here.
So if you only had 3 weeks of back pain, you'd never get surgery for something like that. That's always going to be non-surgical. So what about when things are persisting? What are your non-surgical options?
Yeah. So usually the progression are first to diagnose it. So obviously, you know, we'd use physical therapy programs. A lot of the times your pain's in the back, so we want to strengthen the core. It kind of helps with that movement, as well as, you know, here we have osteopathic manipulation therapy as well in spinal mobilization treatments. Our physical therapy here is great, whether it's here in Chillicothe or around the region. Acupuncture is another type of treatment to help release endogenous opioids and help with chronic pain. And then obviously I think that next bullet point is very important. You know, talking about biofeedback. We call it CBT, cognitive behavioral therapy. It's very simple. It helps you understand really why are you having your back pain and where is it coming from, and you know what's causing it, what makes it worse, what you can do to help alleviate it on your own. And so I think that really helps most, you know, help understanding why you're having this pain and what's causing it. Then we have the TENS unit, you know, transcutaneous electrical nerve stimulation. that can help. A lot of times you can request to trial this in physical therapy, and if it helps, we can obviously prescribe you a TENS unit. So this is just a quick slide talking about how we evaluate. Really, you're coming to see me in the clinic, I'm talking to you. How long is this? First of all, where is your pain? Is it in the neck and the back? Does it travel? How long have you had it? What did you do? What didn't you do? What have you tried? And then from there, my number one goal is to diagnose what's the pain coming from, or to get it down to a few. And then once we kind of know what's causing it, then we can come up with a treatment plan. So, what does diagnosing mean? Diagnosing means a lot. Physical exam. After I talk to you, you're going to perform a physical exam to see if your pain is joint related or nerve related. And then the other is obviously we use imaging, whether it be an X-ray image of your spine or neck, or even get into CAT scans or MRIs, to kind of show us a 3D picture of what's going on.
So some of these conditions are non-operative and some are operative. I kind of want to tease the audience with some of the things we're going to talk about that may be operative or non-operative, including lumbar stenosis, disc herniations, instability, and spondylolisthesis, which is when one bone is shifted forward on another. Fractures we got to talk about, especially vertebral compression fractures, and we're also going to talk about sacroiliac dysfunction and some neck problems. So there's more to come in this seminar. Dr. John has already talked about differentiating somatic pain, back pain, from radicular type neuropathic pain. So why don't you tell us a little bit more about sciatica and treatment, Dr. John?
So, sciatica is one of the largest nerves that starts in our low back and radiates down our leg. Obviously, it runs from the spinal cord to your buttocks. We kind of talked about what that pain feels like. If you've ever sat on a toilet for too long, you're compressing that nerve. It really runs down the back of your leg, and it can cause weakness in the distal foot as well.
One of the most common things we all encounter, and one of the most common conditions in spine, is lumbar stenosis. Many patients come to me saying, I was told I had stenosis. Dr. John, give us a little background on lumbar stenosis.
Well, lumbar spinal stenosis, stenosis is a fancy word for saying tightening. So obviously, what's taking up space or what's being tight in the spinal canal? Is it a disc bulge? Is it pressing on the nerve root? Is it pressing on your spinal cord? Very common reason to have back surgery. Especially in people over the age of 50, your spinal cord is just asking for more room. It's that simple. Yeah.
I think it'd be a good portion for me to take over on.
Okay. Yeah. Dr. Walker, you're an expert on non-operative and especially operative treatment for stenosis. Tell us a little bit more about what you see on an MRI and other things and how you treat it.
Yeah, so these radiographs you see over in the center portion are MRIs. They're T2 weighted images, and on the left side you can see a normal cross-sectional view of a spinal level where the vertebral body or the bone is in the front. So you can also see the back portion of the bone, and in the middle you can find the spinal canal, that white portion with the end of the spinal cord and the nerve roots kind of in gray in the center there. So the normal spine that should look something like that, where you have a wide open spinal canal, you don't see any dark disc bulges or ligamentous or facet hypertrophy or overgrowth. On the right side is a stenotic representation or narrowed portion of the spine, and you can see the dark portions underlying the bone, which in the front you can see a disc bulge, and then in the back that black is overgrown, a facet joint and ligament overgrowth as well. So you can see where the nerves are usually free to float around, they're compressed into a small space in that V shape.
So I often tell my patients it should look like an eyeball with plenty of white spinal fluid around it and the nerves in the center. That looks like a triangle. So if we see triangles, we get nervous. Next
Absolutely.
slide. So this is a representation of a cadaver, and I'll steal a little bit of your thunder here. So this is a broad-based disc bulge. These are things that can cause the stenosis. This is a ligament, this yellow stuff. And these are the nerves right here. Remember that triangle? If we see the triangle, that's bad. You know there's stenosis. If it doesn't look like a nice eyeball, if it looks like a triangle, it could be due to disc bulge, the thickened ligaments, joint overgrowth, that's called facet joint hypertrophy, all those contribute to the triangle or compressing the nerves. And Dr. Walker is going to show you some other things regarding lumbar stenosis.
And then really quick, this is an interspinal spacer device. This is a minimally invasive option for some that can help increase that stenotic space. What that device there, that purple device, it's Vertiflex. So you can it's called an interspinal spacer device. You can call it a spinal jack. It kind of goes in and it kind of increases your space. So who has lumbar stenosis? This is for our people who not only have back pain when they stand, it builds and builds and builds. It can travel down your legs. One of the biggest questions we ask is, do you get relief with leaning forward? It may not be immediate, or sitting down in sort of in a flexed position, and then you're kind of doing that throughout the whole day. Something very common, I'll ask my patients, they're like, no, Dr. John, you know, I stand fine, or I don't stand at all. And then I'll ask them, hey, do you notice you can stand or walk longer when you're at the grocery store using a shopping cart, just even if it's leaning forward? And if you can, before you feel that pain, it's another sign that is indicative of spinal stenosis. So this is an option. As you can see, that nerve root is red. We've kind of put this spacer device and kind of increased the diameter space by a few millimeters, but those few millimeters means all the world to that nerve not being touched.
So in well-selected patients, this is a good option in the literature. If you get relief when you bend forward, that device kind of opens up the space, and it's pretty easy to put in a short procedural thing. I wouldn't call it a surgery.
Yes, yes.
So what are your surgical options that you typically do, Dr. Walker, for lumbar stenosis?
Well, first of all, I guess it would be useful to talk about the indications. So, you know, when you fail non-operative management, all those things that Dr. John spoke about, the physical therapy, acupuncture, TENS, epidural steroid injections, things like that, you have persistent symptoms involving your low back or radiating pain into the buttock or leg. You fail your non-operative treatment, then you know you're kind of due for a surgical evaluation, and you'll come in to see a surgeon at this point in time who will review your radiographs, so that's your CT scan, your MRI, and you know, in the event that you have spinal stenosis, we kind of have to do a physical examination and find out what your exact symptoms are. And we're looking for neurological deficits. That's the weakness, numbness, tingling in your legs, or symptoms consistent with that narrowing, and we call that neurogenic claudication, what Dr. John was just talking about, where you have compression that causes a irritation of the nerves that go into your legs, relieved by bending forward. Those are the kind of indications that allow us to want to proceed forward with surgery if you fail non-operative intervention. With those requirements or with those criteria, people generally have good outcomes with regard to their lower extremity function and radiating pain going into their legs.
In what situations, Dr. Walker, will you go for immediate to surgery when you see a patient? Will those factors?
That's a great question, especially when you have a neurological deficit resulting in profound weakness of especially the foot. So we call it a foot drop, where you have issues putting your foot down or raising your foot up, a weak limb, a weak extremity. Those are things that lead us to more emergent surgical intervention. Long-standing weakness that has been present more than a couple weeks is more difficult to reverse, and that's less of an emergency, however, still an urgent situation. When we do run into a patient who's failed a conservative treatment and does have radiographically confirmed stenosis, we do like to have surgical discussions, and the most frequently performed procedure is going to be a decompressive laminectomy, where we come in from the backside and make an incision down the back and remove the covering of the bone. You can see that picture, the cartoon of the spine on the bottom right side. The level above has an intact bone all the way up and down, and the level below has, they've surgically removed the lamina and spinous process to decompress that level. If there's significant narrowing on these sides, we call that the lateral recess. If Dr. Fleming could point out, actually that top left image has some lateral recess stenosis. If there's significant lateral recess stenosis, sometimes the stabilization of the spine, the stability of the spine is decreased, so that might require augmentation with rods and screws, and we call that a spinal fusion. Another indication is spondylolisthesis or spondylolysis. That's a fancy word for slippage. So you can see on this side view of CT scan the alignment of the spine at L5 and S1, if Dr. Fleming could point that out there. there's a significant slippage. You see the alignment's abnormal, and that blue arrow on the left side points to a acquired or a congenital fracture, depending on I don't know in this particular patient, but that fracture is not new. It's been there for a long time, and that instability has allowed L5 to slip forward on S1. And the slippage is once again outlined on the right side. And this is often a pain generator, because if that segment is mobile, when you bend forward or backward, that's bone on bone rubbing against each other, and that can create significant pain. Additionally, you can see the areas where the nerves exit out, the neural foramen, if Dr. Fleming could point that out, yep, all those little holes. The nerve, as it exits out at L5S1, can be compressed there, causing a radiculopathy or a radiating pain down the leg, which is similar to a sciatic pain. That can also cause numbness, tingling, or weakness.
I notice here, Dr. Walker, not only do you have the forward slippage of bone 5 on the sacrum, but it's essentially bone on bone. There's space between these bones, and this is resting on the other bone. So
Yes.
Is this one of your cases?
This is one of my cases.
Okay, so what'd you do for that?
Oh, that required a spinal fusion. So we call this procedure a transforaminal lumbar interbody fusion, or TLIF for short. And what we do is start by putting some screws into the L5 and S1 pedicles to lay our outline for stabilization, and then we take off the lamina, as you saw in a previous picture, the lamina and spinous process. That's the decompression. We come out to the side a little bit, and we actually take off that facet joint on either side, usually the more symptomatic side, and that gives us direct access to the patient's disc space, and in that case it's the very collapsed level there. So that bone on the side comes off, and we have access to that disc space. We take out the disc using a series of instruments, and then you can see that implant that we put between L5 and S1 to facilitate a bony fusion. We use rods and screws to promote immediate stabilization, but the actual healing fusion occurs when bone growth occurs between those two segments and on the backside where we did the surgery as well. So that's the arthrodesis or bony fusion that we look for. And then additionally, you can see that slippage there has been reduced or corrected on the right side of the screen. So we pull everything back into alignment, and we stabilize that position. So those nerves aren't being compressed, and there's no more motion between segments.
You're not giving yourself enough credit, because I also noticed that it was bone on bone before, and now you have a cage that's giving you some height restoration as well.
Exactly.
And that further decompresses the nerves as they exit. So instead of the keyhole being closed, it's opened up again. So,
yes, it is.
Nice work.
Thank you.
So there's other things that we treat for instability of the spine, other conditions, and trauma is one of them. And we do trauma here at the Adena Orthopedic and Spine Institute. Tell us a little bit about trauma in this case.
Sure. In this case, this is another one of my patients from a couple weeks ago. Actually, it's a 60-year-old female who fell forward while working. She came to the hospital complaining of back pain, and at that time a plain film was obtained showing a compression fracture, but upon further imaging we got this MRI scan, which actually you can appreciate the bright white signal extending all the way kind of diagonally, indicated by those blue lines or the blue arrows, to the soft tissues of the back. So this is actually a 3-column injury, which is a very unstable type of fracture. These almost universally require segmental instrumentation, like a fusion process. If we go to the next slide, I think I have some pictures of that. Oh, we're on to actually another note. You can note with this patient, this is a picture of the thoracic spine, a cross-sectional view, and the pedicles, or the conduits between the back of the spine and the front of the spine, measure only 4 millimeters, which is extremely small, very difficult to put a screw through with a traditional method like traditional X-ray fluoroscopy in the OR. So it becomes essential at that point in time to have additional technology to aid you in the OR so you're not hurting a patient by misplacing a screw. Next slide, please. So one of the technologies that we recently acquired here is called the Noarm. It's by a company called Medtronic, and it allows for stereotactic, meaning image-guided placement of a multitude of spinal hardware. I used it for this case. The device itself is a open loop that closes around the patient intraoperatively. There's a reference array that attaches onto the patient's bony anatomy, and a series of x-rays are taken through that circular tube. And the navigation console, which you can see a demonstration of that in the bottom right corner, reconstructs that into a 3D image that we can use to accurately place screws without actually having the patient open on the table through a traditional midline incision. So we can use multiple small stab incisions off to the side without visualizing the anatomy open, and the computer actually tells us where we are and that we can accurately place screws using minimally invasive techniques like this. Next slide. So you can kind of see a demonstration of the size of the stab incisions that we would use on the back. They're very small, about 1.5 centimeters, 2 centimeters sometimes. That middle image is the post-operative X-ray that I obtained, showing the pedicle screws and rods going from T10 to L2. You can see the compression fracture, or I'm sorry, the 3-column fracture right in the middle there. And then that last image on the right side is a front-back view showing the accurately placed screws. And these minimally invasive procedures result in much less hospitalization time. This patient actually went home the next day, less than 24 hours after surgery, and is doing very well.
Okay, that's beautiful work. Great that we have an O-arm, and we essentially, with the O-arm, we never leave the operating room because there's a spin prior to waking the patient up without knowing 100% that screw is perfectly placed. So you will not walk out of the operating room with a screw not perfectly placed. So that's a wonderful technological advancement for us at the Adena Orthopedic and Spine Institute. I have a few questions from the audience. I don't want to get too far away, and so I'm going to run through a few of them. We'll start with Dr. Walker. After surgery, is physical therapy needed, and can they come to my house?
It depends on the surgery and the patient. Some people, I like to say the way you come into the hospital is the way you leave the hospital with my surgery. So if you're coming in functional and you just have a radiating pain down your leg, you might not need physical therapy. But if you're coming in significantly debilitated, you've got some weakness that needs recovery, physical therapy can certainly be of great benefit. The timing also depends on the type of surgery. If it's a simple decompression, then physical therapy can be initiated early. If it's a spinal fusion, then we like to kind of delay a couple months while your body forms bone around the instrumentation. That's an important part. So during that portion, at least for spinal fusions, we like to limit the bending, twisting, and turning of whatever body part we fused, and then we limit the amount of weight you can lift as well. So physical therapy in general is used pretty frequently.
I'm going to let Dr. John take this question. What if I'm not a surgical candidate due to poor health? What are my options?
I think we have plenty of options. Obviously, we talked about the conservative measures, and then our next goal, especially if surgery is not indicated, is just diagnosing what the pain is. So whether it's from a disc protrusion, maybe an epidural steroid injection may be appropriate for you to get steroid right at the active component causing your pain. And we talked about some joints that we treat, the SI joint and the facet joint. So so if you're coming to receive an epidural because you're having disc bulge pain, what do you expect? By the time you lay face down on my table, probably takes 5 to 10 minutes to perform, but you're gonna feel a pinch and a burn. That's numbing medication. Burns for a second. You'll be happy it's there. Hopefully you won't feel the track of the needle. And then once we enter the epidural space, which is right outside of that vertebral body and right inside his instrumentation right there, then we kind of confirm that with contrast to make sure we're in the right spot. Otherwise, me and my colleagues don't inject. And and once we're in the right spot, we kind of inject steroids. So the numbing medication wears off by the end of the day, but hopefully the steroid kicks in around day 3, day 5, and like Dr. Walker said, our number one goal is to get you back to your prior level of functioning.
Dr. Walker, I'm going to let you take this one. After surgery, am I able to go home? What if I live alone?
That also depends, it's highly variable depending on the case. A lot of our surgeries are done as a overnight hospitalization, so if you get surgery on a Thursday, you go home on a Friday. Although some longer fusions or longer surgeries might require a more extended hospitalization. In the event of you not being able to take care of yourself at home, there are multiple options. There are subacute rehab facilities, long-term assisted care facilities. Nonetheless, if nobody's available to take care of you, we find a way to get the job done and make sure that you're safe. Additionally, if you might be able to go home and take care of yourself somewhat, we do have services where, an aide can come to assist you a couple days a week, maybe 3 times a week, with bandage changes, bathing, washing, all the essentials.
Okay. I have a lot of questions, so I'm going to just ask a couple more, then we'll continue. I'll let Dr. John answer this one. How do you know when it's time to consider surgery?
That's a great question. When you're having chronic pain, what's chronic pain? Pain that's kind of existent for more than 6 months and not really being alleviated. Usually, the protocol or the steps to take is you probably go to your primary care doctor having acute back or neck pain. They'll get imaging. If that's sort of not improving with conservative measures or physical therapy, you're coming to see myself or someone like myself. Number one goal is to diagnose the pain, and at that point, we're talking about interventional techniques where we're using X-ray guidance to specifically get to the root cause and try to help not only diagnose but help provide treatment. So, patients who are having chronic pain for over 6 months and the medications are just being escalated and still not really able controlling your pain, whether it's nerve pain medications, muscle relaxants, narcotics, you probably should see a specialist just to confirm and also diagnose where your pain's coming from and what we can do about it.
Okay. My next question I'm going to use as a segue to the next topic, and the question was, is anyone too old or too young for surgery? So we're going to move into the next topic, which is compression fractures. I can tell you from my experience, I've done a 94-year-old kyphoplasty who had a vertebral compression fracture, did fantastically well. So sometimes if it's, obviously they have to be healthy enough to undergo anesthesia, but there are sometimes we operate on very elderly patients, and sometimes we operate on very young patients. I had a disc herniation my first couple of years of practice. The patient was 12 years old with a huge disc and a radiculopathy, went through all the conservative things that Dr. John talked about. It was in my board collection, so I was really nervous about doing it, and I did it, and I defended it, and and the patient did great. So that's 12 to 94 right there. So I would say get an evaluation, and we will make a decision whether surgery is best for you or non-surgical treatment is best for you, but we're willing to take all comers. So tell us about compression fractures, Dr. Walker.
Sure. Every year there are more than 700,000 compression fractures. That's way more than hip and wrist fractures combined. And under the realm of that is burst fractures, which are a little bit worse than a typical compression fracture, and then your 3-column unstable burst fractures. 150,000 people in the U.S. are hospitalized due to pain and medical management associated with vertebral compression fractures. That's obviously a huge impact on the healthcare burden. That's $1.6 billion annually. And then osteoporosis-related disability translates to more bed days, more hospital bed days than stroke, heart attack, and breast cancer. Next slide. So osteoporosis itself is a skeletal disease characterized by decreased bone strength that predisposes the patient to fractures. On the left, you can see a picture, a microscopic picture of what normal bone structure looks like, and the osteoporotic bone or weakened bone is on the right side. Vertebral compression fractures come in a couple major conformations. There's a wedge fracture where the front of the vertebral body comes down to almost a triangle or a wedge. The biconcave type of fracture where you have central loss of height. And then the crush where you have a diffuse loss of height. There's also, not listed here, a burst type of fracture where you have, we call it retropulsion, or a fracture of part of the vertebral body into the spinal canal, and that can cause neurological deficits. So how we treat these, we like to apply the same methodology as our other surgical treatments. People usually have to fail conservative management. So the natural course of these fractures is that they heal over 6 weeks to 3 months. In the event that a patient has a worsening fracture, intractable pain or pain that doesn't get better with medication that prevents them from getting out of a hospital bed, or pain that persists beyond that healing period, vertebral augmentation is available. So it's a surgical technique called a kyphoplasty or vertebroplasty. In this picture, it's a kyphoplasty, which is minimally invasive. We enter the front of the vertebral body through the backside, so through kind of like we place a pedicle screw. You can see in the middle picture there's a needle carrying a balloon that is inflated in the vertebral body that attempts to restore height. You see the difference in the height of the vertebral body between the first and the second picture over there. And then within that lumen or space that the balloon has created, we put a type of bone cement. And that serves two functions. It restores structure to the bone in that cavity that we created, and it also, during the curing process of the cement, it causes some of those nerves, the pain nerves, to no longer function. So it's almost an immediate pain reliever for these types of fractures. It's a very effective procedure.
Have you ever done one of these, Dr.
I did one the other day. This was actually, I believe, is this an L2? L2, I think. And you can see the dark cement within the vertebral body. This was an elderly patient who couldn't get out of bed. She came to the hospital with this fracture, had significant disability, and wasn't going to be able to mobilize, so they wanted to send her to a subacute rehab facility instead of home. And we just took her to the OR and put some of this cement in. You can see how it crosses each side and kind of restores some structure, and this patient ended up going home instead of to a rehab facility.
I want the audience to know that the Adena Orthopedic and Spine Institute and the Spine Center within that institute is comprehensive. So we don't just treat back problems. We treat tumors, we treat fractures, and I think you have some familiarity with neck problems as well. So let's talk a little bit about neck problems and a common condition there.
Sure, and a lot of people complain of neck pain, but what's frequently missed is the painless issues of the neck, which are the more concerning surgical issues. The conservative treatment can be applied to the neck as well as the low back, and a lot of those things that Dr. John talked about, the conservative measures can also be done in the cervical spine or the neck. What I am very cautious to look out for are the painless things that affect upper extremity functions. So if you have spinal cord compression in the neck, it can cause arm weakness, arm numbness, arm tingling, issues with your fine motor skills. So a lot of people say that they drop objects or they can't button buttons or zip zippers anymore. Some people have issues with balance, or they say they're falling more frequently, and these symptoms are concerning for something called cervical spondylotic myelopathy, or spinal cord compression causing those symptoms. Those are the outlines of the things I just spoke about. So we can see on the right side, that's a picture of a relatively normal neck. You can see the gray spinal cord coming down in the middle, the vertebral bodies in front of that, and the white is your spinal fluid. So you want to be able to see a nice spinal fluid plane all around the spinal cord. So that's a normal spine. Next slide. This is one of my patients, a 68-year-old male with right arm weakness. You can see, if you compare to the initial image that we had, there's obviously less of that white spinal fluid signal within the center. The vertebral bodies don't look as well defined as they did before, and you can see how they have some bone spurs coming out of the back as well as black disc bulges running down. It kind of looks like an accordion. Where that blue arrow points between C4 and C5, there's a fairly sizable disc bulge that's pressing on the spinal cord. There's a cross-sectional view of that on the right side. And similarly to the lumbar spine, you should be looking for that white spinal fluid around the gray spinal cord in the middle, which is not present. It's kind of in that triangle shape, which we don't like.
No, that does not look like an eyeball. The triangle is bad.
Yes.
What'd you do for this?
So the procedure for this is called an anterior cervical discectomy and fusion. It's a surgery from the front of the spine. I make an incision on the right side of the neck. It's about maybe 2 centimeters in length. I localize to the level of your problem. So in this case, C2, C4, 5 right there, you can see a little needle in there in the disc space, the vertebral body above and below. And then I move the breathing tube to the side, the swallowing tube to the side, and that gives me great access to the entire disc space. I use a series of instruments to clean that disc space out and a drill to take off any bone spurs that might be causing compression. There's also a ligament that's sometimes thick that I take out as well to fully decompress the spinal cord. Since there's no more disc in place, I do have to put an interbody spacer, and it's a cage made of titanium that I pack with bone that Dr. Fleming is pointing to up there. To keep everything stable and in a correct position, I put a plate with a couple of screws in the front. So altogether, that's an anterior, meaning from the front, cervical, neck, discectomy, and fusion.
How long do these patients usually stay in the hospital?
These patients go home the very next day in most cases, less than 24-hour stay.
And what type of symptomatic relief do they typically get after the surgery?
They often have some immediate functional recovery. Patients experiencing pain in their arms or radiculopathy often wake up not feeling any pain at all. Patients with more severe disability might feel improved strength after surgery immediately, or changes in balance. But overall, you can have recovery of function up to greater than a year after surgery. So these provide immediate and delayed relief.
In the neck, sometimes patients are afraid of the word fusion. Tell us about some other options
Absolutely.
for neck surgery.
So there's a cervical disc arthroplasty. Multiple companies make them, but this is an example of the Mobi-C LDR and the Prestige. And it's very similar to the anterior cervical discectomy and fusion in terms of the procedural basis. You make an incision on the front of the neck, move the breathing and swallowing tube to the side, take out the disc, and you can see this was actually a 2-level surgery on the left. There's the artificial disc replacement above and below, and you can actually do these at 2 adjacent levels. And this is marketed as a motion-preserving surgery. So instead of losing a couple of degrees of motion per level, you maintain that ideally. So it's perfect for younger, active patients.
And other proponents of this will also say that you may spare the risk of another level getting bad years down the line.
Yes.
By preserving those forces in there. So you do this as well. So let's move to a common condition. Next slide, where the sacroiliac joint you talked about before. We heard about some of the non-operative treatments. Let's talk about how we diagnose and treat sacroiliac joint pain. And the nice thing about this condition is patients can usually point right at a spot off the midline to the right or left as the thing that's causing pain. So tell us a little bit about sacroiliac joint pain, Dr. Walker.
Sure, it happens from transfer of load from the body of spine to the lower extremities, so it's basically where your spine meets your pelvis. 15 to 30% of back pain arises from the SI joint, so especially in the past few years, it's being appreciated as a significant pain generator in a lot of patients who previously weren't offered surgery. There's a disease burden similar to hip and knee arthritis, so it's very ubiquitous or present throughout society. The 5-year cost to Medicaid is almost $300 million, and as Dr. Fleming alluded to, people complain of pain kind of off to the side, and we call that that's the SI region. So that's called the Fortin finger test if you have pain over the kind of side of your gluteal region. It's due to cumulative wear and tear of that joint. It does have a couple of degrees of inclination or movement, so if that becomes lax over a number of years, and you get additional degrees of movement in that joint, you can experience pain. There can also be pregnancy-associated laxity of that ligament overlying the SI joint. You have one in the front and one in the back. So having a child can certainly predispose you to developing this type of pain, as can infection, lumbar fusion, spinal fusions, and stress fractures. So physical examination, just like we examine the spine, we like to examine the SI joint to rule out any type of SI pathology or sacroiliac pathology. So we do a spine, pelvis, hip, and knee evaluation, as all those can kind of overlap in their symptomatology. I mentioned earlier the Fortin finger test, or pain localized over the SI region, and just like the indicate or the picture of there shows, people kind of point to that off midline portion of their low back with one finger and say it hurts right here. So it's the bottom medial portion of the spine that you can feel when you touch your SI region. As I mentioned, there are multiple ligaments that support this joint. You have some in the front on each side circled in red, and then a robust network of them in the back overlying that joint as well. So it is a moving joint. It's irregularly shaped. It's almost like a reverse C, and has many ligaments. So how we diagnose this, actually I myself don't do the diagnostics, Dr. John does these, but if I see a patient and I'm concerned that they have SI joint pathology, so when I do my physical exam, if they have that Fortin finger test and multiple other maneuvers that I can do on an exam table, I'll send them to see Dr. John, and Dr. John will do a diagnostic SI injection. You can see these radiographs on the side. Localization to the SI joints, and then they put the needle into the joint. You can see some contrast going into the joints in that bottom left picture, and then there's just a side view, and that's usually with a local anesthetic, and we're looking for very short-term pain relief. It sounds kind of counterintuitive, but we're looking for you to get immediate relief for a small amount of time, and if that diagnostic is positive, then we have you back in the clinic to talk about an SI fusion. So here's a case presentation. There's a 54-year-old female with 1 year history of low back pain. Has an MRI of the lumbar spine with disease where the nerves exit out. We call that the neural foramen. The spine, hip, and knee examination is within normal limits, so there's nothing abnormal or sinister appearing on the physical examination, except there is a positive Fortin finger test, so she has pain over that SI region. And she failed conservative management with the typical epidural steroid injections, non-steroidal anti-inflammatories, physical therapy, and everything else. So this system is called iFuse, and it is a SI fusion or an SI joint fusion system. You can see there are 3 dowels made of titanium that harvest bone as they're placed through a small 3-centimeter incision on one of the sides, kind of overlying the hip region. Those three dowels go in and stabilize the SI joint, and as they harvest bone on the way, eventually over the course of months, you'll form a bony fusion across that joint, stabilizing it, similar to a spinal fusion. It can be weight-bearing within weeks, and it's a very effective procedure with the right indication.
Yeah, well-selected patients do excellent. Unfortunately, Dr. Walker, we as spine surgeons know that back surgery, even in well-selected patients, sometimes does not work, and patients will still have chronic pain, back pain, or maybe some neuropathic pain. Dr. John, what are our options, or what do we think about in patients who've had, say, back surgery that didn't work out for them?
Yes. So, we have something called spinal cord stimulation. So, say you're a patient, you've had a surgery or two, helped alleviate the pain for a little bit or not quite. At this point, what spinal cord stimulation is, we can attempt to put 2 leads on top of your spinal cord and send an electrical signal in hopes that we block the pain signal not only in the back, but everything below. And we do something very similar for the neck as well. So what we do is, if you're appropriate for this, we try to sign you up for a 7-day trial. What's a trial? We put the 2 leads in, and then that external battery, we don't implant it because obviously, it's a trial. So, we don't want to cut you down or make an incision if not needed. So we sterilely secure the external battery pack to your low back region. You go home for 7 days, you test drive it. What we're looking for is greater than 50% relief, and actually if it increased your function, mobility, or gave you a quality of life. And then you're seeing me, if you did do that, then you're seeing me back in the operating room, and we are implanting that where the 2 leads go, that's pretty much the same procedure, but obviously I'm anchoring down the leads so they don't move. You can see if they move, we're getting a whole different distribution of nerve roots. And then obviously I'm making a little 2-inch incision in your right or left buttock region just to tuck in that battery. So this is a dorsal root ganglion stimulation, DRG. So what this is another form of spinal cord stimulation. Let's say you had a fusion, a lumbar fusion from L4 to S1, which had revised. You're still having back and leg pain. Both your legs are affected. Spinal cord stimulation is an option for that. So that way we get the back and both lower extremities. Let's just say, hey, it's just your right knee. You had ACL repair, everything structurally looks great, but you're having burning pain. It's like someone throwing hot oil on your knee. We don't need to stimulate your back and both legs. We just need to get the nerve supply that supplies the knee. So as you can see, as the nerves exit, that's where those electrodes are actually stimulating rather than right over those 4 electrodes. Exactly. So it's a more targeted approach when you're trying to provide this technology to a specific region in the body.
Dr. Walker, what are some of the surgery requirements and processes you go through before a patient gets to surgery?
It starts with a clinic visit, of course. So patient comes in. I like to get a thorough history, so discuss with you, where your pain is at, where your numbness or tingling is at, when it started, anything making it better or worse, and the thorough history and a physical examination. So I'll have you, move your arms, move your legs, check your reflexes, do my other maneuvers. And with that, I like to correlate those findings to an MRI image or other type of radiology. If you can't get an MRI, a CT scan is acceptable. If you've failed non-operative management, then we have a surgical discussion. If you haven't attempted non-operative management, I don't like to do surgery unless I absolutely need to. It should be a last resort. So I usually refer to one of my pain colleagues to initiate the conservative therapy, physical therapy, epidural steroid injections, things of that nature. If there is surgical pathology on the MRI, failed conservative management, then at that point, I discuss with you, I look at the MRI findings, I show you the pictures, and I propose what surgery I'm going to do. If we both agree upon that surgical plan, then I have you meet with my surgery scheduler who can help you pick a date and get the pre-admission testing process started. So I don't operate on anybody unless I know it's going to be safe. I have you see your general practitioner or primary care physician for medical clearance. If you have a cardiologist, I have you see them as well. And between all of that, then you get on the surgery schedule.
What happens the day of surgery?
The day of surgery, you'll come in, you'll get greeted by the surgical desk concierge who will check you into the pre-operative area. While all of this is happening and they're kind of updating your history, I'll meet you in the morning, say hello, we'll go over the surgical consent again. While that's being done, the room is being prepared, and eventually you'll get brought back into the OR. During that time, you can't have food overnight, so that's just something to keep in mind. You'll come into the OR room and you'll meet all the staff, and then you'll get put to sleep by the anesthesia team. You'll wake up after the procedure is completed in the post-operative care area, or the PACU. And from there, I'll come and see you again and make sure that you're doing well, and you'll get transferred up to the inpatient floor, which is just above our ORs.
So it sounds like the Spine Center is offering a very comprehensive service, from non-operative things, from physical therapy to injections to spinal cord stimulators, even if the surgery didn't work. It's an exciting time here at the Adena Orthopedic Spine Institute. We have 40 providers. We have this state-of-the-art building, which everyone should at least visit. Tell us, I'll let either one of you start talking a little bit. Why should you do your care here, home, locally at Adena?
I think I'll echo what most of the physicians here would say, in that you get coordinated multidisciplinary experience when you come here. As Dr. Fleming mentioned, you have pain providers, non-operative sports med, orthopedic surgeons, neurosurgeons, orthopedic spine surgeons, all in one building, who frequently talk to each other, run cases by each other to optimize your outcome. It's also a dedicated surgery center, so orthopedic surgery center, so we only deal with orthopedic pathology, which includes the spine in this institution. It's a hospital within the community, so you're treating your friends, the community members. The physicians actually care about your outcomes and want to make sure that you're doing well at all times. One exciting thing is the new technology that we have in the OR, and that's something that I discussed previously with Noarm, and we have 6 brand new ORs with cutting edge technology, brand new equipment. It's a very exciting time.
Dr. John, why don't you tell us about our interventional pain team? Since 90% of back problems can be treated with you guys, tell us a little about our tiered delivery program.
Absolutely. So these are our other colleagues. The top 4, top left, that's Dr. Matthew Santiago. Top right is Dr. Andrew Porter, myself, and Dr. Zhang. So we are all interventionally trained pain management physicians, and we're lucky enough to have Regina Tolliver, who's almost as good as us, pretty much. She's great to have on board. She is our nurse practitioner, and so we will evaluate the patient. We'll get incoming referrals, and then we'll kind of discuss or diagnose the plan of care, and if you need to take that next step to surgery, or if you need to trial some minimally invasive options or conservative measures.
So you basically come into the system with one initial spine provider, which can be one of our sports medicine physicians, neurologists, or interventional spine physician. They will do some conservative treatment, epidural steroid injections, Vertiflex, whatever you come up with, and then and only then, if that fails or they have a neurologic problem, will you need a spine surgery consultation. So it's a continuum of care for the patient. Dr. Walker, why don't you talk about a surgical spine team a little bit?
Absolutely. It's a nice picture you have of all of us over there. On the far right, that's Lee Holdren. He is our nurse practitioner. Dr. James Fleming and myself in the middle and the left side, respectively. In our practice, as we've mentioned previously, we have 2 spine surgeons, multiple pain management physicians, neurologists on the same floor, several of them, sports medicine specialists, which are operative as well as non-operative, as well as physiatrists. So those are rehabilitation physicians who specialize in getting you back on your feet.
So coordinated comprehensive care. And it's all in our new beautiful 110 square foot Adena Orthopedic and Spine Institute. Please come and visit if you haven't. I got a question that said, do I need a referral if I'm having back pain? You can come into our system, you can call us. There's a website you can go to. And you can ask your primary care physician for a referral, or you can just call I don't know the phone number offhand memorized, but just, there it is, 740-779-4598, and we'll get you in to an initial spine provider. It might be a physiatrist, it might be interventional pain, it might be sports medicine, but the message is, don't worry about, trying to figure out how to see me directly. Come into the system and we'll take care of you. I have many more questions. I appreciate the interest and time that you have. I probably have about 5 or 6 more questions, but we're already past due. Please call us if you have a further appointment. I'd like to thank Dr. John and Dr. Walker for their time, and we look forward to taking care of you and your families. Thank you very much.